So let's move on with looking at pulmonary function. Let's first look at how we control what we breathe. We can think about and intentionally breathe in and out, but we can also do it unconsciously. So when we're talking voluntary control of breathing, that starts in the frontal lobe, that starts in the motor cortex. And what happens is it sends signal down to those respiratory neurons through the corticospinal tracts. This is only the way voluntary control of breathing occurs. When your carbon dioxide levels may rise too high, your automatic controls will take over. It's kind of the thought process of when a child throws a temper tantrum and they say, "Mommy, I'm holding my breath until you give me what I want," and they hold their breath. At some point, the body will take over and unconscious control of breathing will happen, and the child will pass out and everything will be fine. So this is something that starts in that motor cortex in the frontal lobe. Okay, we're talking the cerebrum, travels down through those cortical spinal tracts, and it bypasses the brainstem. So what we're seeing here is we're seeing it bypass, it's this red one, bypasses the brainstem. Airflow is governed by the same principles of what controls or what influences pressure, resistance, and flow of blood flow. Okay, the difference is that it's a gas versus a liquid. So the flow of a fluid is usually directly proportional to the amount of pressure between 2 points. When you push on that syringe, the pressure is going to increase inside the syringe and push the fluid out. The flow of the fluid is also inversely proportional to resistance. So the higher resistance you have where that fluid is going, the more difficult it is going to be for that flow to get there. So it will slow down flow where there's higher resistance. You see atmospheric pressure being kind of that baseline, what drives respiration. So the weight of that air down above us is going to be what's going to influence our inhalations and exhalations. Okay, so your atmospheric pressure is lower at higher elevations. When you go to Flagstaff, the atmospheric pressure is going to be lower than it is here down in Phoenix. So there's a couple of laws that we look at. We've got Boyle's law, which states that at a constant temperature, the pressure of a given quantity of gas is inversely proportional to its volume, which means the amount of pressure that's on a gas at constant temperature is the opposite of what its volume. So look at it this way. When you've got constant pressure, so you've got air in a box, and you all of a sudden stretch that box out so that it gets bigger, the pressure inside that box is going to be lower. Or if you shrink that box and make it smaller, the pressure inside that box is going to be bigger. Now imagine that box is your lungs. So if the lungs contain a quantity of gas and you expand the lungs, the volume, the size of the lungs increase, which means the pressure inside the lungs is going to decrease, causing air to flow in. And then as the lungs recoil and the volume decreases, the pressure within the lungs is going to increase, pushing air outside or forcing us to exhale. The unit, when we're looking at pressure used by respiratory physiologists, is centimeters of water. So we're not looking at millimeters of mercury like we do in our atmosphere. It's centimeters of water. And this basically measures how far a column of water would be moved by a certain pressure. It's more sensitive than the mercury because mercury is a heavier liquid than water is. So when we breathe in, we've got intrapleural pressure, which is that slightly negative pressure that sits or lives in between the two pleural layers. So if we look at the pleural membranes of the lungs, those are the intrapleural space, that potential membrane that lives there, similar to that of the heart. You have a slightly negative pressure that exists between those two layers, which kind of causes those two layers to stick together. So when you have the recoil of the lung and tissues, that causes the lungs and the chest to pull in opposite directions. When you're looking at these two layers, there's a slight film, okay? It's a watery fluid that creates a surface tension that allows those interpleural spaces to stay together. When you're looking at the pressure, you're looking at about -5 centimeters of water within that pressure or within those layers that result from the recoil and movement of the thoracic cage. So you've got those layers that cling together through the cohesion of water. So when the ribs swing up, the parietal pleura follows them. And when it recoils, you have that negative pressure forms and that visceral pleura clings to it because of the cohesion of the water. This also, when you have those two pulling together, it also pulls the alveoli and stretches those alveoli into a larger space to allow for more exchange of gases. The second law that we need to look at is Charles's law. So when you have a gas and that volume of the gas is directly proportional to the temperature of the gas, the higher the temperature goes, the bigger the volume on the gas. Because think about it, it's like a house party. The more active those molecules are within those gases, the more they push against the side, the more they're going to want to expand. So you have the increase in pressure. When you decrease that temperature, okay, or when you decrease that temperature, that volume is going to decrease as well because the molecules just aren't as active and they're not bumping into the sides as much. This also affects how the lungs expand. So on a cold day, it will increase on a cold day, when you breathe in, you've got your difference between the outside temperature and the inside temperature of your lungs. What you need to do is you need to equalize or steady that temperature. That is what the tissues of your nasopharynx are for. That's why you have the meatuses, to allow for that moisture and that warming of the air as you breathe it in. So inhaled air on its way into the lungs is warmed to about 99 degrees Fahrenheit by the time it reaches the alveoli. This allows the volume to expand the way it needs to in order to contribute to the inflation of the lungs. So as we look at quiet breathing, the dimensions of the thoracic cage will increase, or its total volume will be about 500 milliliters. It'll go up and down about 500 milliliters in just normal quiet breathing. So let's look at this. When we have the air come in and we look at those bucket handle that lifts those rib cages up, okay, ribs swing up in a bucket handle shape, you've got the intrapleural pressure here, which, remember, you've got the intrapleural pressure between the layers of the lung, which is at about -5. When the bucket handle goes up and your ribs go up for inspiration, that pressure decreases to -8. At the same time, you've got the intrapulmonary pressure that decreases to approximately -1 centimeters of water. All of this allows for the air to move into the lungs. And then as we have recoil and we expire, the intrapleural pressure then increases, okay, because it goes to -8. It goes back to that -5, that normal. So it's allowing the tissues to recoil, and if that recoil increases the pressure, because we're talking negatives here, as well as that intrapulmonary pressure moves to about 1 centimeter, +1, which pushes the air out. And it's that normal, quiet intake and out push of air. So this passive process, remember, relaxed breathing is diaphragm flattening out as it contracts and ribs going up. Exhalation at this point is a passive process. We don't actively push the air out of our lungs during normal quiet breathing. okay? When we force our breathing, our accessory muscles get involved, and that can raise our intrapulmonary pressure to about 40 centimeters of water. And we've been through this in the picture previously. Issues that you have. So when you have air in that pleural cavity, those spaces, it's called a pneumothorax. It happens when you have a puncture in the wall of your thorax. It can happen surgically when they surgically place a tube. Basically, what happens is when you're breathing, as you breathe in, air is being sucked into that wound, into that pleural cavity. That potential space, rather than being a potential space, then becomes an actual space and becomes air filled. So what you see is that loss of that negative pressure. So going back here, you have that loss of that -5, and that pressure then starts to go up. Atelectasis is basically a collapse in the part of the lung. It can happen from an airway obstruction, because think about it. When your lungs are absorbing gases, it doesn't stop. Your blood is still flowing. So as your lungs are absorbing gases, it's kind of like a vacuum that the gases continue to be pulled out of the alveoli, eventually pulling those villi and collapsing them, much like a vacuum does. If you were to plug up the end of a vacuum, the hose will flatten out. All right, so moving on, let's talk about resistance. Two factors influence how much resistance is in our lungs when we breathe. We've got the diameter of our bronchioles as well as the pulmonary compliance. So the diameter of bronchioles, that's pretty self-explanatory. That's bronchodilation or bronchoconstriction. So dilation means increase in diameter, constriction means decrease in diameter. Epinephrine will stimulate a bronchodilation, an increase in the diameter to increase airflow. This is initiated through sympathetic stimulation. On bronchoconstriction, usually you see constriction from histamine release, parasympathetic nerves. Cold air can cause bronchoconstriction, as well as chemical irritants. All of these serve to decrease the size of the airways that eventually will decrease airflow. With a decrease in airflow, when you go to extreme cases, you can suffer from suffocation from extreme bronchoconstriction. Usually this happens with an anaphylactic reaction, anaphylactic shock, or with asthma. So the other half of this equation is pulmonary compliance, which means how easily do your lungs expand. Your lungs should be pretty compliant or pretty flexible, okay? With degenerative lung diseases, maybe COPD, maybe emphysema, you'll see a decrease in how well your lungs move, thereby a decrease in compliance. Usually when you see scar tissue, the tissues become stiffened and less movable. Compliance is limited by the surface tension of water within the alveoli. So there's a thin film of water on the inside of the alveoli. Surfactant is secreted by the great cells within the alveoli and disrupts the hydrogen bonds between the water molecules to reduce surface tension. When you're talking about infant respiratory distress syndrome or ERDS, we see this in premature babies that lack that surfactant. So they're treated with surfactant or artificial surfactant that allows their body to have that compliance or that ability to inflate the lungs or the alveoli for that gas exchange. And the babies are treated with this artificial surfactant until they can begin to make their own. Once they make their own, they're taken off of that medication because their body is functioning normally again. So when we look at ventilation of that alveoli, remember it's controlled by diameter and compliance. The only air that, only the air that enters the alveoli is available for gas. If it's not within the alveoli, there will be no gas exchange utilizing that air. But when we look at it, not all inhaled air gets there. There's about 150 milliliters of air that fill those conducting zones of our lungs. Remember, the conducting zone is the pathway or the hallways that you use to get to the room, which are the alveoli. So your conducting zone is also known as your anatomic dead space because there's no gas exchange there. And this can be altered based on dilation of your sympathetic nervous system. Dead space can increase with this sympathetic stimulation, but it allows for greater flow, which means more air is getting to the alveoli. And then you have your physiologic or your total dead space. What you see is as people have lung disease, they will have some areas of their alveoli that are unable to exchange gases due to scar tissue, due to lack of flexibility of the tissues, whatever. I mean, fluid pneumonia will cause physiologic dead space. So the sum of all of that dead space, both the anatomic dead space where the passageways are, but as well the alveoli that aren't working, that sum total is called physiologic dead space. So if a person, going back to that normal restful breathing, 500 milliliters of air in and out, you add on to that 150 milliliters that stays in those anatomical hallways, you only have about 350 milliliters that actually reaches the alveoli with each breath. So when you look at your alveolar ventilation rate, that's the amount of air that reaches the alveoli, that 350 milliliters, and then you multiply that by how many breaths a person takes in a minute. Okay, that's the respiratory rate, usually about 12. Alveolar ventilation rate on average is going to be about 42 milliliters per minute. This is crucial for the ability of the body to gain access to oxygen. This is where the oxygenation of tissues come from, is that alveolar ventilation rate. And then when you're breathing out, you can't breathe out all of your air because you still have air in those passageways. So your residual volume is the milliliters or the volume of air that you can exhale with maximum effort, that amount that's left over in the lungs, no matter how much you breathe out. So when we're looking at these measurements, it's the spirometer that measures and captures the expired breath and records the variables such as rate, depth of breathing, speed of expiration, oxygen consumption within the body. The spirometers are what measures all of these variables in ventilation. So let's look at these volumes that we've got. You've got your tidal volume, that's the restful, normal inhale and exhale of one breathing cycle, 500 milliliters. You have your inspiratory reserve volume. Okay, your inspiratory reserve volume is the amount of air that you can breathe above that normal restful breathing. So you breathe in and you out, normal. When you are breathing in again, rather than breathing back out with the cycle, breathe in as much as you can, and that's your inspiratory reserve. That's about 3,000 milliliters. You have your expiratory reserve, which is on the opposite side of it. So gentle in and out breathing, but rather when you exhale, rather than breathing back in again, push out as much air as you possibly can. That's about 1,200 milliliters. That's your expiratory reserve. So as much as you can possibly breathe in and much as you can possibly breathe out voluntarily is your expiratory reserve. Your residual volume is the amount of air that remains in your lungs after your expiratory reserve. So after you've pushed out everything you can actively push out, whatever is left over, because remember, your lungs are not collapsing when you're doing this, that's your residual volume. Those are the different components, okay? So tidal lung, inspiratory reserve, expiratory reserve, and residual. The rest of these all are composites, okay? They're additions or they're figured out due to adding things together. So when you look at your vital capacity, that is as much as you can possibly breathe in, all the way out to as much as you can possibly breathe out. So it's the addition of your expiratory reserve, your tidal volume, and your vital capacity equals your expiratory reserve volume, your tidal volume, and your inspiratory reserve volume. This number is in and about 4,700 milliliters. This is an important gauge when you're looking at how healthy your lungs are, because you want to be able to breathe in and out a maximum amount. If anything is prohibiting that, then you know that there's some sort of disease process going on. You've got your inspiratory capacity, which means how much you can possibly breathe into your lungs, which is the sum of your tidal volume and your inspiratory reserve volume. Okay. These two here. That's how much you can breathe in. Your functional residual capacity is the amount of air remains in your lungs after a normal tidal respiration. So it's this expiratory reserve volume and your residual reserve volume subtracted by your tidal. Okay, so let's look at functional residual capacity. Functional residual capacity starts at the tidal. Okay, so it's the addition of your expiratory reserve and your residual volume. Not necessarily so easy. You've got to find your residual volume first before you can figure out what your expiratory reserve volume. There's some calculations, and we'll go over this in lab. And then your total lung capacity is the sum total of all of your capacities within your lungs. So it's the reserve volume plus the vital capacity, which equals about 6,000 milliliters on average. So going back to the spirometry that measures all of these things, when we start to assess and diagnose off the spirometer, we start to take a look at what things are affected or what capacities are affected within the lung. So if you see a reduction in pulmonary compliance, which means you can't breathe in a whole lot, that's a restrictive order. Any disease that produces any type of fibrosis, pulmonary fibrosis, is an example of a restrictive disorder. Black lung disease, tuberculosis are both restrictive disorders, that they don't allow the lungs to be inflated to capacity. Obstructive disorders basically are blocking the airflow into the airway. So the passageways, your bronchi, are constricted too small in order for air to move in or even move out. Asthma and bronchitis are both examples of obstructive disorders. And then you've got emphysema, which is in a category of itself because it's both restrictive and obstructive in its disease process. So emphysema is a combination of both restrictive and obstructive disorders.